Next up, we have some clinical case presentations with Miguel Agrate. Miguel earned his degree at the University of Puerto Rico School of Medicine and completed his residency training at the University of Puerto Rico Hospital in Carolina. He then completed fellowship training in primary care sports medicine at Georgetown, where he obtained expertise in musculoskeletal medicine and procedural ultrasound. He's currently the program director at the San Lucas Hospital Ponce Health Services. Health Sciences Emergency Medicine Residency and Sports Medicine Director at Praven Health Clinic. He also serves as team physician for the Puerto Rico Baseball Federation and the Guaynabo Mets of the BSN Puerto Rico Basketball League. Miguel?
All right. All right. Can everybody see the screen there? All right. Well, thank you for having me. Afternoon, everybody. What we're going to do today is I'm going to go through a few cases in the ER where kind of MSK specific knowledge was helpful in making the diagnosis and figuring out what was going on, and just kind of give you some ideas as to what doing a sports medicine fellowship can how it can make a difference in your EM practice. Let's see. I have nothing to disclose. The reason this is important is that obviously we see a huge number of MSK related visits in the ER, roughly 25% depending on what book you use to look at that. Also depending on what book, it's either the most common or second most common liability issue. Mainly because of a lot of misdiagnosis and a lot of treatment that is subpar, that leads to harm down the line. Unfortunately, there's a lot of literature on how MSK exam skills are lacking in not just in emergency medicine, but throughout primary medicine. So a lot of the times we don't make the right diagnosis. So the treatment is, again, subpar. The other part is that in a lot of places where we work, the patient complains of pain in their whatever, and then by the time we see them, they already have x-rays that are reported by radiology, and we kind of go based on that, and we minimize kind of what we do on our exam. So try not to be over reliant on imaging and try to do the exam, and we'll kind of go through these when the cases that we're going to discuss, but these are the reasons why this matters. So if we miss the injury, if we misdiagnose the injury, if we don't treat it appropriately, it leads to loss of function. It can lead to chronic pain. If we don't obtain follow-up, same thing. So all of these things can lead to significant harm down the line, and that leads to legal issues for us. Beware triage bias, right? So the patient with arm pain, unless we're thinking that it's an MI, is kind of inherently we're like, well, I'm less worried about that person than the next guy. Same thing with leg pain, same thing with knee pain, same thing with back pain. But that's not always the case. And a lot of serious illness can present with MSK complaints or what appear to be MSK complaints. So make sure you're getting a good history, make sure you're getting a good exam. And if imaging has already been done, or if there's been some type of provider in triage situation, make sure you're getting your own exam. Make sure you ask the patient where it actually hurts and see if they need more imaging or they need different imaging. So right on through to the cases. So the first one, this is classic EM. So we have 52-year-old male. He has a bike accident. He's an avid bike rider. He comes in on his own. EMS showed up, but he's like, no, I can walk, and he just kind of walked. It happened near the hospital. He swerved to avoid another vehicle, and he didn't hit his head or anything. He just swerved. He was able to slow down, but he fell to the ground onto his wrist and hand, and he's complaining of wrist pain, knee pain, and chest wall pain. Seen by provider triage, and basically they get x-rays of everything that he's complaining about that has pain. So we have wrist x-rays, we have hand x-rays, we have knee x-ray, and chest x-ray. And all of these are normal. These are not the patient's x-rays, although the next slide will have some of the patient's own imaging. But something like this. So, right, we have a guy who falls from a bike. By the time we see him, these images are already done. There's nothing too exciting on these images. These images already have radiology reports, and they're reported as negative. So we go see him, and he has pain in his wrist, and he has pain in the anatomic snuff box, and he has pain with axial loading of the thumb. So we're concerned that there might be something going on with his scaphoid. So that image right there, that's what a scaphoid looks like, and I'll show you the another image in a second here. And then this is what the patient's scaphoid look like. The this here is the radius. This here is the scaphoid. Same thing over here. This is the scaphoid over here. This is not what it's supposed to look like. We should have a nice, smooth, clean arc of muscle of bone there. So this patient, yeah, maybe we would have gotten this based on his exam. Maybe we would have said you need to get a repeat X-ray, or you need an MRI down the line, or you need evaluation by hand surgery. At least where I work down here in Puerto Rico, even though it's kind of in the middle of a city, we're essentially practicing rural medicine, and getting follow-up appointments can be very difficult. So making these diagnoses and confirming that this patient has a scaphoid fracture is actually really important. We can actually set them up with the appropriate imaging and testing down the line. We don't have good follow-up here, so getting this diagnosis done on the initial visit actually makes a big difference in how we manage it, making sure we give the right instructions, and making sure this patient has the right level of care. And I actually sent these images over to the hand surgeon, who was able to see him and be like, okay, send him the MRI, and I'll see him next week. And this gentleman ended up needing a pin in his scaphoid. The other thing is he has a normal chest X-ray, but he's very significant pain in a very small area in his lateral chest wall, and we decided to put our ultrasound probe on it, and there we go. So right there in the middle of the screen there is a rib fracture with a small associated hematoma. Sometimes these can be hard to do. So these ultrasounds can be hard to do. The ribs are not flat bones, so you have to kind of get small pieces of the rib at a time. But generally, if you go right where it hurts the most, like if you ask patients, like, where is the most significant pain that you have, and you put your probe right there, there's a good chance you're going to be right on that fracture. And then if you have not just the fracture, but an associated hematoma, then you know that that's where the fracture actually is. This gentleman, once we found the fracture, which again was not on the X-ray, we were able to tell him you have a rib fracture. We were able to treat it accordingly. We actually ended up doing a block on this gentleman, and he went home pain-free and had good follow-up. He ended up having good outcomes. I followed him up in my clinic, actually, and he did well out of all of these injuries. But this would have been a patient that, without a good exam, if we just go by the X-rays, if the ER is busy and we're not really paying attention to what's going on, maybe he doesn't get told all of this, and then he comes back a week later and he's got atelectasis, or he's got other issues, or he's got avascular necrosis of his scaphoid. So by recognizing these injuries at the time and treating them appropriately, the patient's outcome was therefore much better. Moving on to the second one here. So this was an interesting one. This patient has a car accident in Colombia, in kind of rural Colombia. They're going from one major city to another one in Colombia. They fall down a ditch, so it's actually similar to that picture. And they get transported from the scene to a small rural ED that did not have any real imaging capabilities other than X-rays. They didn't have labs. They didn't have anything else that they could do. So they just get X-rays. She's told everything's normal. She has the brilliant idea of somehow getting on a plane and flying to Puerto Rico just to get medical care right after that happens. And she's a very large lady, and when she shows up in our ER directly from the airport, she does nothing else other than go from the car accident to an ER, essentially to the airport in Colombia, to the airport of Puerto Rico, and then to our ER. She shows up with a bunch of X-rays, or X-ray reports rather, that say that they are all normal. And what happened there? There we go. Sorry about that. She's not really able to ambulate without assistance. She has a lot of pain in her knee. She's got bruising essentially from the area of her breast all the way down to her hips. Like her whole abdomen is just one big bruise. That turns out that that is partly because she'd had a procedure in Colombia, a cosmetic procedure in Colombia, in addition to her car accident. So this was kind of a very odd situation when she shows up in her ER, and we're not really sure what's going on. But we obviously she has bruising and pain, so we get, and she had been in a big wreck. We get the appropriate imaging for a major trauma. There's plenty of bruising and swelling in her abdominal wall, but there's no internal injuries, thankfully. But when we keep, evaluating her, we're like, she's still complaining of this knee pain with a negative X-ray. She's got this very odd fluid collection in the anteromedial knee that we decided to put an ultrasound probe on. And this is the distal thigh anteromedial knee. And there's just a very, very large fluid collection that's located below the skin layer and in between the skin layer and the muscle layers. This is not a joint effusion. This is fluid outside of the joint that is very, very liquid, very, very fluid. As you can see here, this is not a lot of pressure on the ultrasound probe that causes the fluid to displace. This is a Morel-Lavalley lesion. So these are actually fairly common injuries, and they're way less recognized in the emergency medicine literature than they should be. So internal degloving or closed degloving injury. Basically, this patient, when she was in the car accident, her right knee was pinned, and she had to kind of rip it out of the car when she fell into the ditch, which led to that shearing type force that basically broke apart those vessels, lymphatic vessels, usually that separated the fat and fascial layers, and that fluid accumulates there. That fluid does not clot. It stays very, very watery because of what the composition of the fluid itself. The problem is that fluid, if it's a small Morel-Lavalley lesion, we can probably leave it alone. But large lesions, large fluid collections tend to have very poor outcomes if they don't get taken care of. Now, there are certain places where trauma surgery will take care of these. There are certain places where ortho will take care of these, and even sports medicine, we can do these kind of things in the clinic. For this patient, she sees me in the ER, and we decide to drain it to prevent the main complications of this. So because that fluid is just kind of hanging out there, this can get infected. This leads to very poor cosmetic outcomes and can lead to chronic pain if it doesn't get taken care of, and it can be very, very hard to treat if it's a more chronic injury. So we decided to do the following. Hopefully you can see it here, but you'll see the needle coming in from right to left there on the screen. And we just do an ultrasound guided drainage of this fluid collection. So the video was moving. I don't know if it's not moving, but basically we do an ultrasound guided drainage of the fluid. We drain a very, very large amount of fluid. This is just one of the syringes that we took out. It ended up being over 100, I believe 120 mLs of this very, very, very watery, bloody fluid collection. And all we did was we drained it, and then we put some compressions around it, and we had her follow up, in this case with sports medicine, but it could have been trauma, it could have been ortho, depending on who deals with these. And she ended up doing really well. So sometimes these have to be injected, or we have to do sclerotherapy, or a bunch of other things that don't really come into play in emergency medicine. But these are the type of injuries that get missed very, very frequently. And we focus on, is there a fracture or not? And that's the most important thing, yes. But sometimes there can be significant soft tissue injuries that we should recognize, and in this case, manage to prevent harm down the line. So this is the type of situation where this patient, if this had become infected somehow, this could lead to necrotizing fasciitis, or this could lead to very severe injury, perhaps even loss of the limb, if she has a severe enough injury. Oddly enough, although I don't see these that often in the ER, we ended up having another person come in like less than 2 weeks later. So it was, having not seen one in the ER for a few years, I ended up seeing 2 in 2 weeks, as kind of these things happen. And the other gentleman did very well as well with drainage and compression. All right. moving on to the third patient. So this gentleman comes in with elbow pain. He was at a resort in the Dominican Republic, and he played a whole bunch of tennis. And he believes he has terrible tennis elbow, but he's coming to the ER. He's having a lot of pain, and he was seen at the resort. They had some type of physician there. He was diagnosed as having tennis elbow. He was given steroids, so oral prednisone, to take as a taper, but he's having worsening pain. Vital signs are all normal, but this is when you examined him, you asked him to fully extend the affected arm. This is all he could do. So full extension, he's very, very limited in extension at the elbow. And that is not something that should happen from a soft tissue injury. So this is even with passive range of motion. So even if I try to move his arm into a straighter position, it could not get there. So there's some type of block to full extension in this case. And whenever you see someone who can't fully extend at the elbow, you should immediately think that there's something going on in the joint. And usually that's going to be seen as some type of fusion in the joint. And on X-ray, we were very used to looking for effusions on X-ray as either sale sign if it impedes or posterior fat pad. The X-ray report is normal, but when I look at the X-ray, there does appear to be a fat pad there, which would suggest an effusion. So I decided to, the elbow itself looks fine. There's no trauma, there's no injury. It's not hot, it's not red or anything like that. But I decided to put my ultrasound probe on it. And this is what we find. So this is a longitudinal view of this patient's elbow. So what we're seeing here at the very top of the screen, this is triceps muscle and tendon. The bright white at the kind of top right of the screen of the image there is the olecranon. So this is the triceps muscle and tendon inserting into the olecranon. And then all this black stuff below the tendon, that is fluid. So that's what an elbow effusion looks like in long axis. So basically in this case, you just put the probe right behind the elbow, and I'll show you how to do that in the next couple of slides. But this is what an elbow effusion looks like. This is the fat pad is actually this thing that's displaced. So the fluid is displacing the fat pad, and that's what we can see on X-ray. This is useful mainly because we shouldn't have occult fractures. We should be able to, if you have an X-ray and you don't know whether there's a fracture or not, or whether there's a fat pad or not, you can stick the ultrasound probe on it, and if you find that there is fluid, then we know that there has to be some type of injury that's causing the effusion. So this is the same image, but labeled. So there's triceps, in this case, muscle. The tendon is a little bit over here. The triceps tendon is actually very, very small. This is the olecranon, where the triceps inserts. And then if you see fluid below that triceps tendon, that is an elbow joint effusion. Whereas if there is a fluid collection above the triceps center, or superficial to the triceps muscle and tendon, that is outside of the joint. So that's a bursitis problem, that's a cellulitis, an abscess, whatever. So that's what this patient on the right has. But the one on the left, which was our patient, had an intra-articular effusion. So even with a normal X-ray, if you see an effusion on an ultrasound in a patient with elbow pain, that patient either has a fracture or they have something else that's causing an effusion. In this case, this patient doesn't have any real, this isn't just another view, this patient doesn't really have any history that would suggest why this person is having an elbow effusion. He had no trauma to the elbow. So what we decide to do is we decide to put a needle in it and drain it. So an unexplained effusion is always a concern. And in this case, this is how you would do it. So I was showing you the images in long axis, which is what we're looking at here, where the tendon is in long, the triceps tendon and muscle are in long axis. But if you go 90 degrees and you go in short axis, the triceps tendon is this right here. The triceps muscle and tendon is this right here. This is the effusion. So this is the fluid collection inside the elbow joint. And if you go at 90 degrees, you can go in with the needle in plane, as you will see momentarily here. The needle is going to go through the triceps tendon from lateral to medial. And you will see that the fluid drains away in the next few seconds. There we go. So there's our needle. The fluid, the black is all now is gone. So we've drained that. And rather surprisingly, once again, our patient, this is the procedure, and this is what we pulled out of there. So elbows don't hold much fluid. So this is 12 milliliters of pus, of purulent material. Um, it's a good thing that we decided to put the needle in this because this patient ended up having a very odd presentation of septic arthritis, and he had spontaneous septic arthritis of his elbow. Um, he had an extensive workup to figure out why this happened, and there was no great answer. But this patient had septic arthritis of his elbow, which was being managed with oral steroids for presumed tennis elbow, which this was definitively not. So this is one of those situations where you need to be you should be mindful of the possibility of septic arthritis, and you should always consider it in your differential, especially if there's an effusion. Anytime there's swelling in a joint, there should be a good reason for there to be swelling in a joint. So if a patient has chronic arthritis and they're complaining of pain after dancing or doing more than usual, that doesn't mean that patient has septic arthritis, but it has to at least cross our minds. And if there is pain with passive range of motion, like significant pain when you tell the patient to just go limp, to not do anything, and you try to move the joint, if there is significant pain with passive range of motion, that should be a red flag to tell you that maybe this patient has something that has a bigger deal going on. And these are not all going to be septic arthritis, but we should at least consider arthrocentesis if there's not a good reason for these joints to be swollen. Unfortunately, no single exam finding or lab finding can exclude a septic joint without actually getting joint fluid and analyzing the joint fluid itself. So acutely swollen joints that don't have a good reason for being acutely swollen, and they're very painful and they have pain with passive range of motion, you should always consider the possibility of septic arthritis and discuss that with the patient and consider the arthrocentesis. A few of the other things that are very commonly missed in emergency medicine, and this is kind of throughout the literature. Posterior shoulder dislocations are missed about half the time. Radial head and supracondylar fractures are missed a lot because the X-rays can be frequently negative. But again, if someone has elbow pain, just stick the ultrasound probe on it. If there's an effusion, you can tell them you have a fracture. And based on their age, it's going to be either radial head or supracondylar fairly easily. If a patient has pain in the area of the scaphoid, we can just, not only can we say, hey, get another X-ray in a week and see what it looks like, we can actually look at this on ultrasound. And this is going to be one of the things that's kind of up and coming. I think this is going to become much more frequently used over the next couple of years to diagnose scaphoid fractures. Classically, we're taught that we miss the second fracture most frequently, but that's actually not true. We miss the first fracture a lot more than we miss any theoretical second fracture. So just be careful, look at your image as well, make sure you're palpating the area where the patient has complaints, see if they need more imaging. Sometimes sending patients to imaging can be problematic, but if there is concern that there's another injury, we should evaluate that. Something like 25 to 35% of Achilles tears are missed in the ER. Again, this is something that should be evaluated with ultrasound. The management is very different than an ankle sprain for obvious reasons. And if we turn a partial rupture to a full rupture, that can make the difference between needing a boot and needing surgery. Low impact knee dislocations, obese patients. Actually, the patient who came from Colombia, this was one of my concerns. Although obviously it ended up being something else. But beware a knee in an obese patient that just feels very loose in all directions. That can be a knee dislocation that's spontaneously reduced, and it doesn't require a big injury for that to happen. Compartment syndrome, we find it too late. Bad soft tissue injuries, be they Morel-Lavalley or neck fasc or whatever, or multi-ligament knee injuries, we miss them a lot. Septic joint, the same thing. Lisfranc is that fracture dislocation complex of the foot. A lot of the times that gets found either on a CT scan, which invariably looks much worse than the X-ray, or if someone decides to get weight-bearing X-rays, which we basically never, ever do in the ER. And I'm not saying that we should, mind you, but at least have that in the back of your mind for patients who have the right clinical presentation. Then hand and finger injuries, The collateral ligaments, tendons, nerve injuries, all those things are very, very easily missed if you don't do a good exam, and they can lead to significant harm down the line, particularly if the patient, uh, plays music, or if they're dominant hand, they can't feel the pencil, they can't type well. All of these things can lead to legal issues down the line if we're not careful. All right, that is it. Anybody have any questions?
All right, thank you, Miguel. Great talk, and I think really important to think about and remember that those, especially the frequently missed things and things that to keep our ER brain and our sports med brain on as we're on shift or in clinic, so we pick up on all those.